Good morning, class. Today we're going to be talking about chapter 5, which covers the TEE or Transesophangeal echo. Remember, what we normally do is a TTE, Transthoracic Echocardiogram. Today we're going to be talking about a TEE. We normally do a TTE. We're talking today about a TEE. So when you're doing a TEE, whenever you're talking to a patient, you have to speak in layman's terms. Main thing is, do not show them that probe before they're like mildly sedated, because it has a long, it's an intimidating looking probe if a person is, if their mind and wits are about them. So a transesophageal echocardiogram, or TEE, is a special type of ultrasound of the heart that produces much clearer pictures than the standard echo that we normally do on the chest. And it is performed using a TEE probe. It's a different kind of probe. This device has a long tube with a small ultrasound probe at the end of it. And the tube is placed into the patient's esophagus, or the food pipe that connects the throat to the stomach. So why do we do it? It's usually done when the doctor wants to look more closely at the patient's heart to see if the patient has a weak heart or if they have blood clots. So another thing is, remember, think of a TEE as a modified gastroscope, and you only use it when the doctor orders it, and you're not the one who's going to be controlling that probe. You're only running the machine. The doctor is the one who's going to be actually performing the exam. So remember a few things. It's electronically steered. It has a flexible, controllable shaft. And again, a tiny transducer is mounted at the distal tip of that shaft. Unlike a regular TTE, a TEE needs a team. You're going to have the sonographer, the nurse, and a physician. So this is what the probe looks like. This is where you have like all the controls. This is what you connect to the machine, and this is what you put down the person's throat. It looks more intimidating in person. This picture is like shrunk down. It's a lot more intimidating in person. This is why you don't just pull out the probe and show it to the patient. You make sure they're like mildly sedated first before you actually get the probe. So remember, you need a sonographer, a nurse, and a physician for this particular exam. So let's talk about them here for a minute. I want you guys to take a look at 1, 2, and 3. The first one says the person starts the IV. They're in charge of the conscious sedation and suction, because remember, there's going to be a tube down this person's throat. So if there's like any type of extra saliva and all that, they'll be responsible for that. They monitor and document the vitals of the patient. And also this word patient education, you're going to see it right here, and right here. The doctor, the sonographer, and the nurse are all responsible for educating the patient. And we all kind of tell the patient different things, but it gives the patient a more clear view of why we're doing the exam, what we're doing, how long it's going to take, and how it benefits them. So for number 1, this person is like in charge of post-care, like of the patient after. So again, we don't run IVs ever. So this would be the nurse. Number 2 talks about preparing the lab, collecting and inspecting the equipment, and patient education, operating the machine, and post-care equipment. That is our job. 3, patient education, inspects the probe, spray anesthetic, insert the probe, perform the TEE, and interpret the TEE. We don't perform a TEE, and we don't interpret the TEE. So obviously, this would be the job of the doctor. So the TEE has advantages and disadvantages. So when it comes to advantages, the TEE has superior resolution because it has that improved higher frequency range, and it also is going to be sitting closer to the heart. Also, secondly, the TEE has multiple scanning planes, and it's also positioned directly behind the heart. So it sits closer than any type of a chest probe that we can possibly use. So I've said this before, but remember, the study is performed after the patient has been sedated. We only perform a TEE if the standard echocardiogram is not clear enough for the doctor to make out whatever the suspected diagnosis is. We also perform this exam for patients who are going to have heart surgery to give the surgeon and the anesthesia team whatever information they may need to help guide the treatment after surgeries. TEEs can also be performed to confirm if the surgical procedure has been successful or if additional repairs are going to be needed before the patient leaves the operating room. Now, the reason why doing TEEs has become more common is because the risk of a TEE is minimal, but the cardiologist will discuss all of that with the patient, or why he or she needs it and why it's different from the standard echo that they may have gotten done, because a lot of people are like, well, why am I paying for this? So other advantages is, remember, the esophagus and the stomach sit very close to the heart. So when you put the probe through the esophagus, you're getting that clearer image. And secondly, it allows the cardiologist to get images of the heart during a procedure, like a surgery or cardiac cath, without having like the echo camera get in the way of that procedure that they're trying to get done. Disadvantages would be, it is an invasive procedure. There's an increased risk of complications, like bruising the person's throat while you're trying to pull it out and all that internal bleeding, all that stuff. Increased discomfort and anxiety. Again, if that patient is not sedated, when you show them that probe, they're like, you're putting that where? Also, because they're being sedated throughout the thing, they have to be monitored throughout the exam, while as with a regular echo, you don't really do so much monitoring. For a pediatric TEE, the probe is smaller. The kid is going to have to be under heavy sedation because they don't normally just lay there. They can't do what you tell them like an adult can. That also needs a well-trained staff, which means more people need to get paid, and it requires other materials that a regular TEE would not. So we wouldn't just get up and perform a TEE just because we want to. We're going to do it when the doctor tells us to. So some indications would be, if they want to find out what the source of an embolus is, they want to find out about a tumor, mass, or myxoma, or thrombus. If the person has vegetations, on a side note, by the way, any patient you see with valvular vegetations usually has infective endocarditis. Just remember that, the two go hand in hand. If they have septal defects, and we do bubble studies for those, a septal defect, normally when you do a bubble study, it's going to show a shunt, like the blood is going to move from one side of the heart to the other. If the person has prosthetic valve dysfunction, aortic valve diseases, and it's used as a guide in the cath lab, if they have cardiomyopathy, if they've had heart failure, any type of valvular heart disease, complications from a heart attack, or a technically limited TTE, meaning when you did the chest echo with the regular probe, you could not see properly what you wanted to see. So the doctor is then going to order a TEE for a better view. If the person has congenital heart diseases, yeah. So I've talked about why we would, like, what the advantages would be. But let's talk about AFib. That's when you have that irregular heartbeat. So why would the TEE be superior to the TTE when you want to rule out a mass, especially if the person has AFib? Well, remember that the TEE is a very sensitive and accurate tool because it has excellent resolution, and it also has those multiple scanning planes, and it also lies posterior directly behind the heart. We don't have that luxury when we do a regular chest echo. And The main thing is when a person has AFib, that's commonly associated with left atrial or left atrial appendage clots, or the LA or the LAA. And if you have a left atrial appendage or an LA clot, it could like lodge and travel somewhere else, which could have been the reason why the person had a stroke. So a third thing would be when we want to look at the most common adult benign tumor, that's what a myxoma is. So again, for your registry, remember, a myxoma is the most common adult benign tumor. It is not a malignant tumor, it's a benign tumor. And normally we will find it in the left atrium. So the doctor recommends a TEE most commonly to provide additional information either during heart surgery or like cardiac catheterizations. I talked about a stroke again, but let me link these together. If the patient has had a stroke and the doctor orders a TEE, it is because they want to try to find what is the possible reason for that stroke. If they want to find a small hole in the upper chamber, that's a shunt of the heart. Maybe the regular echo couldn't see the shunt, but the TEE can. If they want to make sure there's no blood clots anywhere in the heart, maybe there was a view that wasn't clearly seen when they did the TEE. If they're looking for infections of the heart, aka that vegetation or the infective endocarditis, if they're checking the artificial valves to make sure that they're working properly, the sutures are holding, and the struts are not damaged, and also to make sure that the walls of the aorta are not damaged. So you have contraindications. Anytime you see this word, it means why would we not do the exam? So if the person has esophageal conditions, a bunch of throat problems, we would not. If the patient is uncooperative, that's again why you want them mildly sedated, because when they see that probe, some of them are going to be like, nope, you are not putting that down my throat. So if they don't want it, you can't do it. Do not force them to do anything they don't want to do. If they have unstable respiratory statuses, like they can't hold their breath and all that other stuff, gastrointestinal disorders, or if it's easy for them to bleed, or if they've already had internal bleeding problems before, if they have an unstable cervical spine, all those things. But there's a major contraindication, and that is if the patient has severe narrowing of the esophagus or stomach. You never want to shove something down or force something down somebody's throat if they naturally don't have the opening for you to be able to do so. The actual procedure itself takes about 20 to 40 minutes, but the patient is going to be sedated. So it'll take really like 60 to 90 minutes for them to like come back and be like fully functional. If the patient is an outpatient, he or she would be able to go home like after 2 to 3 hours, like once the procedure is done. And remember, the procedure is very safe usually. You are not the one who's mostly going to be going over the risks. You just talk about your part. The doctor will be the one going over the risks with the patient. The main common complaints we hear, some of them are going to complain of a sore throat for a few hours, and they may also complain of an upset stomach. So let them know that that's a common thing. But almost everybody who gets this done can return to whatever their normal life was before they had this done within 24 hours. I'm going to show you a video here. It's a bubble study, or we call it agitated saline. Pay attention, you guys. This is something you're going to be running into a lot in your field.
Hi, I'm Janice Farnholtz-Province.
And I'm Kelly Connell-Phillips.
And this is a quick video on how to do the agitated saline or bubble study.
The following video is an echocardiogram of a heart without contrast. If you notice, the heart is upside down and flipped, with the atria on the bottom of the screen and the ventricles on top. Also, the left side of the heart is on the right-hand side of the screen and vice versa. A few reasons why we perform bubble studies is to rule out atrial septal or ventricular septal defects.
This test might be ordered when a patient is suspected of having a stroke or a TIA. However, if we already knew that they had an unrepaired intracardiac shunt, this would be contraindicated, as well as for pregnant or nursing women.
For the procedure, ask the echo tech if the existing IV is adequate. Usually an 18 or 20 gauge IV is used, and you will be listening for the echo tech to say, "Go ahead and inject." And this is how you do it. Here are the steps to perform a bubble study. Verify that you have proper IV access. Please ask the cardiac sonographer if the IV location will work. Explain the procedure to the patient. Clean the IV port with alcohol wipes, scrub the hub for 15 seconds, or if a swab cap is already in place, that will suffice. Get your 3-way stopcock and connect it to the already primed extension tubing. Ensure that the toggle is pointed off to the patient. Next, get 2 10 ml syringes. One is a saline flush, and expel 2 mLs of saline out of this syringe. Next, get an empty 10 ml syringe and draw in 1 ml of air. Attach both syringes to the 3-way stopcock. Wait for the registered cardiac sonographer to say, "Begin agitating the saline." Then the RN will agitate the saline solution by closing the valve to the patient's IV and rapidly injecting the solution between the 2 syringes several times. The fluid is adequately agitated when the solution appears cloudy. The sonographer will say, "Go ahead and inject." Before injecting, ensure all of the saline is contained in 1 syringe and communicate that the saline is being injected. Open the valve to the patient's IV and inject the saline solution. Injecting. This process may need to be repeated at least 1 more time. The registered cardiac sonographer will instruct the patient to Valsalva or cough. And as the saline is being injected, this is what it's going to look like on the echo screen. So looking at the bottom left-hand corner of your slide here, you'll see that the air bubbles are being injected, which is the right side of the heart. They go in through the atrium.
There's a shunt right here. That's why you see the right ventricles,
they'll go through the pulmonary artery to the lungs, where the bubbles are breathed out.
What you shouldn't see is what looks like a hornet's nest over there on the right side of your screen, which is the left side of the heart.
So since this patient has bubbles on the left side of the heart, they have a positive bubble study. This patient in particular has an atrial septal defect.
And there it is 1 more time.
Again, it's right here. If it travels across, it means that, there we go. Are we there? If you see it traveling across, it means that the person definitely has a shunt. Because what happens is, remember on the right side, the bubbles travel to the lungs. And since there's going to be air anyway, it's going to be dispelled. So you see anything over here in a person with a negative bubble study. A positive bubble study is when you see these bubbles over here. So if you don't see them, it's negative. If you do, it's positive. It means the person definitely has a shunt.
Are breathed out.
What you shouldn't see is what looks like a hornet's nest over there on the right side of your screen, which is the left side of the heart.
So since this patient has bubbles on the left side of the heart, they have a positive bubble study. This patient in particular has an atrial septal defect.
And there it is 1 more time. So when you're all done with the procedure, then you want to make sure to document all of the pertinence, including how the patient tolerated the procedure and the amount of saline administered. Thanks for listening.
Usually you only need like 2 vials, no more than that. All right, so you need to understand shunt direction. So I'm going to show you 2 images here, and I'm going to talk about them for a little bit. You can have a right to left shunt, and you can have a left to right shunt. So first of all, I talked lightly about shunts, but you need to know that a shunt is an abnormal, it's not normal, is an abnormal communication between the right and left sides of the heart, or between the systemic and pulmonary vessels, which allows blood to flow directly from one circulatory system to another. So let's talk about this right to left shunt. Whenever you have a right to left shunt, it allows deoxygenated blood to bypass the lungs and return to the body. Obviously, we don't want that. The left to right shunts you're going to see like a black leak that looks like this. I call it like a mushroom cloud because that's what it looks like to me. This looks like the stalk and this looks like a mushroom. From the systemic side to the pulmonary side. And ultimately, if this continues, remember, the left side is high pressure and the right side is low pressure, right? So remember, if this continues, what's going to end up happening is the pressure on the right side is going to rise. So eventually, it's going to exceed the pressure over here, which is going to cause that reversal of flow, and then it might become this situation right here. So why is this important? I remember earlier I talked about a stroke. So sometimes people, what causes a stroke is an embolus. So because this hole is in the heart, a person can have what's called a paradoxical embolus. And a paradoxical embolus is referring to an embolus that is carried from the venous side of the circulation to the arterial side or vice versa. It's a kind of stroke or any other type of arterial thrombosis that is caused by the embolism of a blood clot or a piece of tumor that travels, or even if it's like anything that breaks off from somewhere and travels from one side of the heart to the other, is called a paradoxical embolus. So let's say it developed in here on the right side, but because the person had a shunt, it went down here and went over here and traveled through the aorta and gave the person a stroke. That is a paradoxical embolus. But if it started here and a piece of that broke off and traveled over here and went to the person's lungs and gave them a pulmonary embolism, it is still a paradoxical embolus. It's just the problem will be different, but they're both equally severe. They're not good. You don't want them. So here's the general appearance of what the probe looks like. I showed you the real picture, but this is a good diagram of it because you need to understand these parts. So the probe is going to be connected to a console, but we're going to assume that's this right here. That's going to convert the electrical signals into moving 2D images, or like a video of the heart. And then the console has controls that changes and modifies the characteristics of the ultrasound that we transmit so that the returning signal can be processed and displayed. So it usually uses not only a video recorder, but also a printer. So let's talk about this handle right here. Can you guys see my arrow? I'm going to put it from the dark to right there. So let's talk about the handle.
Yeah.
So the handle of the probe has two knobs that flex the tip, and it flexes that tip anterior-posteriorly or laterally. And then by slowly advancing or withdrawing and rotating and flexing the probe, it can be optimally positioned by the doctor inside the patient. So there are three main types of TEE probes. You have the monoplane, the biplane, or the omniplane. And the omniplane probe is sometimes called a multiplane probe. So let's talk about the monoplane probe for a minute. The monoplane probe has a single transducer that images in transverse, like at right angles. So like the 0-degree plane, basically. So that was the first one that was developed. But then they found out that there was an issue. So then the biplane probe was developed. And the difference between the biplane and the monoplane is that the biplane incorporates a second transducer that images in the longitudinal plane at 90 degrees. So the downside is the operator has to manually switch back and forth between the 0 plane and the 90 degrees, like manually, and that became a pain. So because of that, the multiplane probe was developed, and that probe has a single transducer that rotates within a housing at the tip of the probe, and this allows the imaging like in all planes between 0 and 180 degrees. Thank God for technology. And it also allows the transverse and longitudinal planes to be used predominantly. So big thing to remember, the multiplane or omniplane probe is the current standard for adult TEEs. It's the most commonly used one, these days. So when you first look at the probes, they all look similar. They all have that flexible shaft. They have the small transducer that is mounted at the distal tip, and they have handles with deflection control wheels and a deflection brake. Remember again, the monoplane is that single plane probe that was used in the early 90s, and it gives perpendicular views. The biplane probe came along a little later. It was better than the single plane, but it was limited because the sonographer had to manually change from horizontal to longitudinal, and the views had to consistently be switched until the doctor got what he wanted. The omniplane or multiplane probe has an array rotation button and an array rotation gauge that helps make things easier. That's the one that goes 0 to 180 degrees without us having to do too much. Final thing before I move on from this slide, the most popular TEE probe today is the multiplane probe or the omniplane TEE probe. So this is what it looks like in your book. So the biggest difference between the omniplane and the biplane and single plane is that the omniplane has an array rotation button, this button right here, and that is located on the handle of the probe itself. So this allows, instead of the sonographer having to do the switching, the physician can do the switching himself. And it allows that physician to, be able to rotate that ultrasound beam from 0 to 180 degrees, and it allows for easy access to every plane that's located between that horizontal and the longitudinal plane. So the array rotation gauge right here is on the monitor, and it tracks that exact position in degrees. So it's always easier for the doctor to be able to just look up at that screen. Give me one moment, you guys. I need to drink some water. So let's talk about TEE probes for the pediatrics. So how is the pediatric TEE probe different from the adult one? Well, the TEE probe for pediatrics is identical to the adult probe, but it has a smaller diameter, it has a higher frequency, and it is more flexible. So this probe, as in the pediatric probe, can be used for patients that weigh as little as 3.74 pounds. Also, adults who have like esophageal anomalies, like a smaller throat kind of passageway. And also, it's very delicate. So sometimes people might need a transnasal echo. The person's going to be awake, but they're going to be mildly sedated most of the time. It's going to be done in a stress echo lab or the ICU or a lab. And remember, it's limited by the patient's size. They don't use this unless they can't do the other type. So it's only used when the other type cannot be used. We now have 3D TEEs, and it helps us get like volume, ejection fraction, checks for valvular heart diseases, tumors, and things like that. We can use a TEE to also evaluate the pulmonary veins. So the windows and views. The windows and views you're going to get depend on the type of probe that you use. Are you using a monoplane probe, which is limited? Are you using a biplane probe, which is also limited, but not as limited as the monoplane probe? Either way, the multiplane probe is the most popular. The patient will be laying in left lateral decubitus. You'll get your standard windows. And the standard windows include the forechamber, the long axis, the mid-esophageal, the short axis, the transgastric, and the upper esophageal. So the depth of the probe is what's going to tell the doctor where he's at. So the upper esophageal window is that 20 to 25 centimeters in depth. The mid-esophageal window is that 30 to 40 centimeters in depth. The transgastric window is via the stomach, 40 to 50 centimeters in depth. And the descending thoracic aorta window, that one you'll know like almost immediately when you see it. So remember, how good the exam is going to be is how good your imaging skills are as a sonographer. You always want to be able to do your job so that the doctor does not feel like you are incompetent. Always make sure you get the windows that they need. Generally, there's 20 standard views. And the main ones obviously are the long axis, short axis, 4-chamber, 2-chamber, inflow, and outflow. Remember, you guys, I'm sharing my screen with you. So if you raised your hand, I don't know who raised their hand. You can just unmute your mic and say something.
Mr. Meeks, it's me, sorry. So would you say the TEE probe is about the same length as the esophagus?
No, it would have to be longer because not everybody has the same length. What if a person is like 7 feet tall versus a person that's 3 feet tall?
Okay.
So it's very long. The doctor just puts in what's needed for him to be able to see what he needs to see. So I would say it's longer than what a normal person's pipe would be.
Okay.
So here's a really good video on the TE on the count of I don't have a TE patient for you guys to see, but this video I thought was excellent. It goes in a little too much information from what I need, but it's very informative.
The TEE probe has a pair of wheels similar to a gastroscope. The large wheel is used to flex the probe forward and backward. Forward flexion is anteflexion, whereas backward flexion is retroflexion. The small wheel can move the probe side to side. This video demonstrates the use of the large geared wheel first to anteflex and then retroflex the probe tip. Next, the small wheel is used to flex the probe tip left and right for fine-tuning adjustments. The probe is progressively advanced in the esophagus to identify different structures of the heart at different levels and assess their function. Probe position at the upper esophageal level will help to identify ascending aorta at 0 degrees and then at 90 degrees, and also the main pulmonary artery and its left and right branches. This view is helpful in identifying any aortic dissection, pulmonary embolism, and correct placement of PA catheter. This is the mid-esophageal view, and the crystal can be rotated to 0 degrees, 60 degrees, 90 degrees, and 130 degrees, and also to the patient's right or left for interrogation. The structures identified are the right and left ventricles and atria, and aortic, mitral, and tricuspid valves. This is the mid-esophageal 4-chamber view, where you can see the right and left atria and both ventricles. There are tricuspid and mitral valves seen in this view. Issues that can be investigated are the 1. ASD presence or absence, 2. Chamber enlargement, 3. Mitral valve disease and pathology, and 4. Tricuspid valve disease and pathology. This is the mid-esophageal 2-chamber view showing the left atrial appendage, mitral valve, and left ventricular apex. Issues explored in this view include 1. LV systolic function, 2. LAA interrogation for clot or sluggish flow, and 3. LV apex pathology. The mid-esophageal long-axis view allows the echocardiographer to identify and measure 1. The LVOT 1 centimeter from the aortic valve, 2. Ascending aorta, 3. Aortic valve, 4. Mitral valve, and 5. LV chamber size and function. Issues that can be answered are 1. Aortic root pathology, 2. Aortic insufficiency, 3. Mitral valve insufficiency and pathology, and 4. LV chamber size and function. This set of images demonstrates the mid-esophageal aortic valve long-axis view. Colorful Doppler is added to the view on the right and demonstrates severe backflow of blood into the left ventricular outflow tract and ventricular diastole. This is characteristic of aortic insufficiency. Based on factors such as the jet width and extent of jet into the left ventricle, this jet suggests severe aortic regurgitation. In this view, you are able to see the 1. Pulmonary valve, 2. Main pulmonary artery, 3. RV, 4. Tricuspid valve, and 5. Aortic valve. Issues that can be answered from this view are 1. Pulmonary artery and valve disease, 2. RV pathology, and 3. Aortic valve stenosis. The mid-esophageal bicaval view shows a number of important structures. 1. Right atrium. 2. Left atrium. 3. Superior vena cava. And 4. Interatrial septum. Issues that can be answered are 1. ASD. 2. Metastatic tumor. 3. Volume assessment from SVC. And 4. Guiding central or PA catheter placement. Further advancing the probe into the stomach gives transgastric images of the heart at 0 degrees and 90 degrees. You can see the 1. Right and left ventricles, 2. Mitral valve, 3. Aortic valve, and 4. Tricuspid valve. Issues that can be answered are 1. Hemodynamic assessment, 2. LV hypertrophy, 3. LV enlargement, 4. LV systolic function, both regional and global, 5. Mitral valve apparatus assessment, and 6. Cardiac output and stroke volume. It is important to remember that the left ventricle is bullet-shaped and may have different wall motion at differing levels. The LV is divided into 17 segments for assessment of wall motion. It is important to interrogate wall motion at the basal, mid-papillary, apical, and apical cap views in both long and short axis in order to understand and document the movement of all 17 segments. The transgastric basal short axis view of the left ventricle shows the basal walls of the left ventricle and also the mitral valve leaflets. Primarily, this view is used to interrogate basal left ventricular function. The mitral valve takes on a characteristic fish mouth appearance in this view. Color flow can be added to determine the location of a mitral regurgitation jet. The transgastric mid-papillary short axis view is visible at a 40 to 45 centimeter depth of probe insertion and a 0 degree multiplane angle. It shows the mid-walls of the left ventricle, the anterolateral and posteromedial papillary muscles, and part of the right ventricle as well. This view is particularly useful for assessment of volume status and ventricular wall motion. Volume status can be assessed by measuring the left ventricular end diastolic diameter. Wall motion is assessed by evaluating whether walls thicken and contract toward a central point. At the mid-papillary level, all the cardinal walls of the left ventricle can be evaluated at once. The transgastric long axis view can be attained by rotating the probe omniplane angle 90 to 120 degrees from a transgastric mid-papillary view. This view gives another view of the anterior and inferior LV walls. It also nicely shows the mitral valve papillary muscles and chordae instances. Most importantly, this view gives another view of the aortic valve, which can be used for Doppler interrogation and assessment of regurgitation or prosthetic valve integrity. This view is particularly helpful in patients with prosthetic valves, which often generate artifacts when viewed in the mid-esophageal long axis. In summary, understanding probe position and crystal orientation will allow you to conduct a comprehensive and systematic examination of all cardiac structures.
All right, you guys. So when you look at these images, you're going to want to memorize these. So A is like the upper aortic arch in long axis, and B is the mid, this right here. It is the mid-esophageal aortic valve in short axis. C is that descending aorta. You already see the DAO in there. In short axis, though. D is the mid-esophageal echo, but it's like in the aortic valve level in long axis. E is transgastric, mid-short axis, and F is mid-esophageal forechamber. So you need to know these. Just for you guys, it's probably going to be on a test or quiz, maybe a midterm, but they're definitely, you'll see them again. I would memorize them and make sure that I know them like the back of my palm.